I have a patient who presented with respiratory difficulty. How can ultrasound help you rapidly identify the cause of the patient's acute dyspnea?
After pulmonary auscultation and a directed physical exam, optimal ultrasound scanning is achieved in the semi-recumbent position.
Deep breath in and out. Once more. And then lay back.
Lung ultrasound can be performed with low or high frequency transducers. Divide the thorax into 4 areas to scan. If your machine has a lung ultrasound preset, select it. However, if your machine does not have a lung ultrasound preset, choose the abdominal setting. You must turn off any advanced image processing such as compounding or harmonics. Now apply a thick gel cushion to the anterior upper quadrant of the right chest. We're going to look at the lung in the sagittal plane. For this, the transducer should be placed with the probe indicator pointed towards the patient's head. On the ultrasound screen, the indicator marker corresponds with the transducer indicator, so the patient's head is towards the left side of the screen. The pleura and lung space can be examined in the spaces between the ribs. Evaluation of the lung with ultrasound relies on the interpretation of artifacts or signs rather than anatomic appearance. The sonographic image is not a direct correlation of the underlying anatomy as it is seen while scanning the abdomen. This is because everything deep to the pleural line is essentially air. Since air scatters ultrasound waves, we must rely on the interpretation of artifacts rather than anatomic structures. This analysis happens following an algorithm looking for pleural sliding, the presence of A or B lines in each view, pleural fluid, and pulmonary consolidation. First, let's talk about lung sliding. Movement of the pleural layers with respiration or transmitted cardiac pulsation indicates the absence of pneumothorax in that area. Absent pleural sliding can indicate a variety of processes. In the setting of trauma, we would be most concerned about a pneumothorax. However, the absence of lung sliding can also indicate a mainstem intubation, lack of respiratory effort, or the presence of adhesions between the lung and chest wall. Absent pleural sliding should prompt additional views looking for a transition point between an area of moving and non-moving lung. This transition is called the lung point sign and represents the transition between normally expanded lung and collapsed lung. This sign is 100% diagnostic of a pneumothorax. The next step is to look for B lines. B lines are bright, white, hyperechoic lines that radiate perpendicular to the probe face. B lines move with the lung sliding and extend from the pleura all the way to the bottom of the screen. B lines indicate fluid within the lung tissue. More than 3 B lines per scanned area is present as part of the alveolar interstitial syndrome. They can be seen in congestive heart failure, pulmonary contusion, or other types of volume overload. Next, we look for A lines. A lines run parallel to the probe face and represent reflective artifacts between the probe face and the pleural surface. A lines signify that there is air deep to the pleural surface. They are typically seen in the setting of lung hyperinflation, such as in asthma or COPD. However, A lines can also be seen in the setting of a pneumothorax. In the patient with shortness of breath and A lines, consider COPD or asthma as an underlying cause if there is lung sliding. If there is no lung sliding, think pneumothorax. Next, we examine the lung base for fluid. The transducer should be moved cephalad and anterior to define the extent of the effusion. As in other applications, fluid appears dark or anechoic. As the effusion progresses, the lung can become compressed. Bright echoes seen within the pleural fluid indicates fibrin strands or clotting. Returning to the algorithm, do we have pleural sliding in all fields? Are there primary B lines or A lines? Are there effusions present? Let's return to our case. Our patient has a history of both COPD and CHF. But what is the predominant problem today? Ultrasound shows pleural sliding and B lines in all fields. This is consistent with CHF, and treatment algorithms can be initiated rapidly after acute diagnosis. If we instead find lung sliding with a predominance of A lines, COPD or asthma becomes our most likely diagnosis. If no lung sliding were present, we would consider pneumothorax in a patient with acute dyspnea. If A lines are present, pneumothorax should be suspected, but the visualization of a lung point confirms the diagnosis. Finally, ultrasound can also be used to evaluate for pneumonia with a sensitivity around 96%, much better than that of supine chest X-ray. The appearance of pneumonia can vary depending on its stage. Early in the disease process, often the first ultrasound finding is a pleural line that becomes thick and bumpy. Next, as the lung becomes filled with fluid, B lines will appear. The B lines will be confined to the area of pneumonia, unlike the diffuse B lines seen in CHF. Finally, as the lung becomes consolidated, the lung tissue takes on an appearance similar to that of liver or spleen tissue.
Ultrasound is a valuable tool in evaluating the patient with undifferentiated dyspnea.